Thanks. Warm welcome, everyone, to today's DCR lecture. It's a great pleasure for us to host Professor Daniel Surbek. He's the co-director and chef arts from the Department of Gynecology and Obstetrics at the Inselspital, and he also leads a prenatal medicine lab at the DBMR, so preclinical research. But before we jump into the lecture, we have some announcements to make briefly. So first of all, a small teaser about next DCR lecture, which will be held on June 24 by Professor Leonard Held. So I've actually worked with Leo. He's the professor of biostatistics at the University of Zurich at the Center for Reproducible Science and Research Synthesis. And he will talk about reproducing the challenges of reproducing published findings from clinical trials. Then a small advertisement for our upcoming Global Health Symposium, which will actually be held tomorrow from 4 to 8 p.m. at Auditorium Ettore Rossi, and which is a joint venture with ISPM, Initiative Africa, and UPD. So make sure if you haven't any plans for tomorrow night, it'd be great to see you there. Then a small overview of our educational efforts at DCR, which are upcoming and which might be of relevance to the audience here. So we have an upcoming course in fundamental statistics for clinicians. This is a relatively new course, but we got very good feedback so far. So I can highly recommend to any clinicians who want to get a better grasp of fundamental statistics, which is an absolute must know for clinical research. Then we have GCP 1 and 2 in September and November, well as a refresher in October. We run the medical grant writing course this year again for medical doctors, PhDs, postdocs who want to learn in this intensive, more workshop-style course about medical grant writing. Successful medical grant writing, which is also a challenge these days with funding agencies being flooded with proposals. So you have to really know how to write a good proposal. Then we have a PPI for clinicians course coming up in June also, and then a RedCap course also in June. If you're interested, just scan the QR code. And if you want to stay informed about the DCR activities, there is some more QR codes you can scan to keep in touch or follow us on LinkedIn. And this brings me to our main event today. Again, a warm welcome to Professor Daniel Surbek, and for taking time today. We know how busy you are as a clinician, and the stage is yours. I'm very excited to hear more about the stem cell-based therapy of perinatal brain injury from bench to bedside, and the stage is yours. Thanks.
Well, thank you very much, Benjamin. Dear colleagues, it's a pleasure for me to speak with you today, and then I will now try to share my screen. I hope this works. Yes, that should be working. So I will speak about stem cell-based therapy of perinatal brain injury from bench to bedside, and I added 20 years of research. So if I speak about 20 years of research, we would stay here for several days. But I try to put that in and give you some insight in the next about 20 minutes. So actually, Nature titled The Age of Stem Cell Therapy, and that was roughly 1 year ago. And this with a good reason. That's the reason is that there is several ongoing trials showing success of stem cell-based therapy, which has been into research since roughly 30 years. and they focus mainly here in this head article about cancer treatment, type 1 diabetes, Parkinson's, but I add also here perinatal brain injury, and I think you will see also at the end of this lecture why I did this. So what's the clinical problem? The clinical problem of preterm birth is actually mainly brain injury, which has potentially long-term consequences on the life of these individuals. So the most severe consequences which can be there is cerebral palsy, visual impairment, hearing impairment, and cognitive developmental delay. And the basis, the pathophysiologic basis of these pathologies is defined quite well in this summary article in the New England Journal of Medicine. And I just show you here the connection between pathophysiology, about some MRT, visual imaging issues, and then also the clinical outcome. You can see here the main insult includes bleeding, intracerebral bleeding, intraventricular bleeding, but also infection and inflammation and hypoxia. This is a triple damage coming in on these brain, which is in the specifically in the very early preterm birth available. And then you can see what's the consequences, which you can also see on MRT or on ultrasound, which is usually hematomas, cysts, leukomalacia, but also diffuse changes. And these changes might in the end up in the clinical consequences of pyramid tract lesions, mainly including leading to cerebral palsy, which can be such as spastic diplegia, hemiplegia, or tetraspasticity, and of course also severe cognitive and neurodevelopmental delay. So where is the clue, the most important clue for this abnormal brain development? And you can see here on the left side depicts the healthy brain development, which is specifically characterized by a good myelination. And the myelination is basically done by mature oligodendrocytes, which must be transformed from oligodendrocyte progenitor cells. And this process is crucial. This is usually protected by the by homeostatic microglia. Now, when there is an insult, including hypoxia, inflammation, here there might be, as a consequences, an increase in the pro-inflammatory microglia, leading itself on one side to production of inflammatory cytokines, on the other side also to an increase of non-reactive astrocytes, and therefore in the end inflammatory reactive astrocytes, leading to a stop here of the process of development differentiation from the oligodendrocyte precursor cells into major oligodendrocyte cells, leading actually to a correct myelination. That means myelination here is impaired, leading also in the end to neuronal apoptosis. And this in itself may lead to cerebral palsy. So what do we have currently as in clinics as treatment strategy for neuroprotection in early preterm birth? You can see here what is effective is antenatal glucocorticoids administered to the pregnant women before preterm birth. Similarly, also intravenous magnesium sulfate prenatally. Then late cord clamping is a very good method also to improve the outcome, the brain outcome of the baby. And of course, also the delivery in a perinatal center. There has been coming up clinical trials with erythropoietin. However, unfortunately, there is almost no efficacy in these babies. And regarding hypothermia treatment, this is an effective neuroprotective measure, however, only in term birth, in asphyxia term, but not available in very preterm babies due to the side effects. So there is new therapeutic strategies needed, and one of the core strategies is actually stem cell-based treatment from umbilical cord. And I want to show you also why. Umbilical cord, in fact, contains in the middle as a protective mass around the blood vessels the Wharton's jelly, and the Wharton's jelly itself has a big compound of ubiquitous mesenchymal stem cells. These stem cells are also found in amniotic membranes and also in the placenta, but those in the Wharton's jelly in the umbilical cord tissue are probably the most potent mesenchymal stem cells available, and they can rather easily be collected because after birth you can just use a part of the umbilical cord. Then you can flush the vessels, take out the vessels, dissect the tissue, and then extract actually and isolate the Wharton's jelly, put it in cultures, and there you have a nice culture of proliferating undifferentiated mesenchymal stem cells, which can also then be stored long time by control rate freezing and storage in liquid nitrogen. So our first project, and now I go 20 years back, our first project to look at this issue was our fetal stem cell transplantation project in sheep. As you can see here, at the time, we used intraperitoneal transplantation of mesenchymal stem cells in these sheep fetuses, and this is in about 1/3 of gestational age. Then we let them be born, and then we analyzed in the end also the function, but also the tissue of these newborn lambs. And this is the main finding we had regarding our project of neurogeneration. That means that we found these transplanted, these were allogenic mesenchymal stem cells from other sheep. We found those rather abundant in the brain cortex, but also in the brain medulla. So there was engraftment, in fact, of these transplanted, prenatally transplanted cells in the brain. And this brought to us, of course, also the motivation to follow this line of research and to look actually also at the effect of stem cell transplantation. But first, we started to more deeply characterize the neurogenic potential of mesenchymal stem cells obtained from the umbilical cord tissue. As you can see here, that's one of the first works where we looked at expression of CD133, nestin expression, neurofilament expression. In this following work, which we titled Turning Placenta into Brain, showing the different also OPC characteristics of these cells, which we achieved when putting these mesenchymal stem cells in certain culture conditions. So with this in vitro work, we were able to also show the neurogenic differentiation potential also into the line of oligodendrocyte precursors and also major oligodendrocytes. Then we make a step further and we realized that it's not only cell engraftment and eventually cell differentiation and replacement of damaged neural cells, but it's also the communication between the transplanted mesenchymal stem cells and the residing neurogenic cells. So, and this is a good summary of how mesenchymal stem cell can influence the surrounding cells in the brain and also foster with this neuroregeneration. You can see here that on one side it increases reactive astrocytosis, it fosters myelination and synaptogenesis. There is a decrease of apoptosis and an increase of neurogenesis. And in the end, and this is probably the most important mechanisms, is immune modulation. In this case, is a reduction of T lymphocyte activation, but also of macrophage infiltration and of microglia activation. So actually there is two lines of potential effectiveness of transplanted mesenchymal stem cells in the preterm brain. The first part is cell differentiation, leading to a neurogenic lineage, which has been proved in vitro, but also in vivo, with a cell replacement. However, what we have seen here in our animal models also, that there is, for a long-term cell replacement, there is only very few of these cells surviving over a long time period, that means over 6 months. However, the probably much more effective part is the so-called paracrine activity. And in this case, it includes the cell-to-cell message by extracellular vesicles, having influence on immune cells, but also in residing brain cells. And as you remember, 2 years ago, that Victor Ambros and Gary Ruvkun obtained their Nobel Prize in medicine and physiology about the definition or the detection and definition of microRNA with this publication at the time in Cell. And this was, as you can see here, over 30 years ago, until it made to the Nobel Prize. But they actually found the issue of post-transcriptional regulation by microRNA molecules. So microRNA is also the focus in our approach with the extracellular vesicles. The vesicles are kind of a vector how to transport these microRNA. We have specifically also defined and characterized these microRNA. We suppose also that if we are going to the direction of cell-free therapy using only these vesicles, that there is less immunogenicity in allogenic treatment. And the second point is also small size means usually a more easy way of administration. So the first is we had to prove that these vesicles coming from the mesenchymal stem cells from umbilical cord do really enter these cells, in this case microglia. So we have made these uptake experiments showing that there is a very high uptake of the vesicles, also showing that there is, in fact, that they are functional. That means that they are decreasing the number of cell death coming from hypoxia. We then switched to the in vivo mouse model. We used the modified Vannucci model of perinatal brain damage, including, as you see here, a microsurgical ligation, unilateral ligation of the carotid artery. In addition, there was general hypoxia applied with 8% oxygen. And in addition, and this is very important, we induced also inflammation in these pups to really mimic what happens in early preterm birth. And we can also show that these measures will lead to a generalized unilateral damage of the oligodendrocytes. Now, the second point is, of course, the application route to the newborn, to the preterm baby, which might only be of a weight of 700 grams. And the approach is here the transnasal approach, as it has been shown not only for medications, but even also for cellular therapy, that this cribriform plate is actually a way how to administer directly agents to the brain, in this case primarily to the olfactory bulb. And we tested this also in these pup in these mouse pups, where we administered transnasally our extracellular vesicles. And this was one of the first work now 10 years ago, where we could show also the result of the functional experiments after the administration of these extracellular vesicles in damaged mouse pups. And we could show also not only by analyzing brain tissue, but also by functional analysis, that there is an effect. And you can see here what we could find with imaging technique, that these in this imaging, these green stained extracellular vesicle, how well they were taken up in the brain of these pups. And they avoided, some of them went to the lung, but mostly will end up in the brain. So this showed us that our theory that direct application through the nose, in fact, is that these vesicles end up at the right point. So the next step was, of course, to see how about the function on the with the immune modulation, and we could show here the effect on immune modulation, specifically on expression of a pro-inflammatory cytokines such as interleukin 1 beta, interleukin 6, TNF alpha, etc., where you can see as an example here, that's the control animals, not damaged, that's the damaged animals, and this is damaged animals after extracellular vesicle treatments, where we could abrogate almost all damage regarding expression of pro-inflammatory cytokines. And with this also we were able to show a decrease of cell death in gray matter zone. And we had some functional experiments, and I just show you this because I like this experiment quite a lot. This is a Morris water maze test. You see here on the left side the control mouse who needs to find the platform. She's swimming around this water maze, and here is the damaged mouse unable to find the platform, swimming around completely dizzy. And here we have an example of a with extracellular vesicle treated animal finding the platform much more straightforward. So also we could show this in functional tests. And here is the summary of our preclinical studies. So we found that extracellular vesicles from mesenchymal stem cells, they contain anti-inflammatory microRNAs with a crucial role also in oligodendrogenesis, that they can be delivered also to neural progenitor cells. They trigger actually oligodendral differentiation in these cells. They are able to inhibit astrocyte activation, reduce inflammation. They showed also functional neuroprotective and neurogenerative effect. So that was the moment where we had to look. So now eventually we should take a step into clinics. And now we had to see what's happening out there in clinical trials. And most clinical trials, there were several ongoing at the time. Most of them were performed in children with already established cerebral palsy, because eventually after 6 months or 1 year or 5 years old, usually they used autologous umbilical cord blood cells, and mostly were treated by intravenous transfusion. And I want to just show you the initial study which have been published, and these are all now clinical studies. That was about over 10 years ago, when this group in Seoul, in South Korea, published this randomized control trial using umbilical cord blood stem cells in children with cerebral palsy. They randomized, and they could find a better outcome, specifically after 6 months in these children. You see the red pintish is actually the motor function, but also mental scales and social cognition function. So there seems to be a clear positive effect of this treatment on the status of these children, and they concluded also that there is an amelioration not only of motor deficits but also of cognitive dysfunction. There have been many more trials. I maybe pick out for you sometimes, and there is, I think that's a very strong research group at Duke University and Durham in North Carolina, with Joanne Kurtzberg in the lead. She's known for stem cell transplantation, not only for hematopoietic diseases, but also for metabolic disorders such as Hurler syndrome in children. And she started to use this approach using autologous cord blood infusion in children with cerebral palsy. That was her first randomized trial, and she could not only show that there is an improved function, but she could also show an imaging, functional imaging, that there is a improving effect, an improve in whole brain connectivity as well as motor function. This study, again, here now for the first time, they used mesenchymal stem cell infusion, again in children with cerebral palsy. Also here you can see, as compared to the control group, how the effect is to improve motor and cognitive function, comprehensive function, and they were all again children with cerebral palsy. This is another trial also now coming from Southeast Asia, using umbilical cord tissue mesenchymal stem cells. Now these are those cells we are focusing on. Again, they could show the effect, and then here again, it's a randomized controlled trial from the group of Joanne Kurtzberg using allogenic cord blood and cord tissue mesenchymal stromal cells, again showing the clinical effect. And specifically here, what was important, there was a certain lab time. That means that the full effect was there after about 1 year in these children. And now there was last year in pediatrics this IPD meta-analysis looking at the effect and of all these clinical studies. You can see here, after 1 month, 3 months, there was no significant effect, but already after 6 months and then after 1 year, so a long-term effect, but also a long-term keeping effect, a positive effect of improvement of gross motor function in these children. So I think from this part of the cellular therapy, there is now pretty clear that effect is there. Now we want to look at the issue of these other children, of the neonates, and this is our population. So these are not anymore children like 5 years old with a severe cerebral palsy, but this is children, neonates, where the brain damage was acute and where actually a prevention of development of cerebral palsy is the aim. So not only the treatment and alleviation of symptoms, but the complete prevention of the severe syndrome. So here is the first pilot 1 trial, also again from the group of Joanne Kurtzberg, and they used umbilical cord tissue mesenchymal stem cells. So these are those cells we are using also in our trials so far. And the neonates, they were term-born neonates with hypoxic ischemic encephalopathy due to an insult during delivery. You can see here these children were all around term. They had a low umbilical cord pH, some of them are very low, and then they were treated at the age within basically 3 days. And they used cord tissue stem cells from allogenic donors. They did not use HLA matching. They just pre-medicated with hydrocortisone. And they could actually show in this phase 1 study that this approach there was no toxicity and that it was a safe approach for 12 months. Now, this follow-up paper of a Dutch multicenter trial published in the Lancet Neurology, and that was 4 years ago, they used this approach in children with a stroke, with a perinatal stroke, up to the age of 5 months here. There was the first 10 newborns with intranasal administration, in this case of mesenchymal stromal cells after perinatal stroke. And what they found, is depicted here, that this approach was safe, and they embarked on a larger multicenter trial. And this they had even here the 2 years follow-up in the neurodevelopment. And obviously also the outcomes were very favorable as compared to historic controls. Now there are further trials looking at, again, these in very preterm infants. So this is the first trials in very preterm infant, in this case using umbilical cord blood. This is again a phase 1 clinical trial. This paper just published also in the JAMA Network Open. They also looked at the effect of extremely preterm infants, in this case with cord blood cells administration. And with this study, this is again a phase 1 protocol, which showed actually this has not been performed. This is just a study protocol of a phase 1 study. And here they used anogenic cells obtained from the umbilical cord. However, they had to they do HLA matching, so they also use hematopoietic stem cells where you need HLA matching, as compared to mesenchymal stem cells where matching probably is not necessary. So this setting, of course, is much more complicated and much more risky, of course, because in theory this could provoke graft versus host reaction. So this comes up to our protocol, and we are at the moment developing this protocol and are in discussion with Swissmedic about the approval. We focus on the use of a off-the-shelf product of extracellular vesicles obtained from mesenchymal stem cells from the umbilical cord tissue. This is actually a first in human approach. It is a non-invasive intranasal administration within the first 7 days of life, and these will also all be newborns, very preterm newborns before 32 weeks, where there is already some imaging indices of brain damage. And the first outcome of this phase 1 trial, of course, is primary the safety outcome, but eventually also the development, the neuromotor development. This study will be performed by the departments of obstetrics and neonatology of Inselspital. So this is a summary. First, peripartum brain injury in preterm birth is caused by local hypoxia, ischemia, and inflammation in the brain, leading to cerebral palsy and long-term neurodevelopmental delay. I've shown you that stem cell therapy is effective for long-term improvement of motor and cognitive function in both animal models as well as children with cerebral palsy. Extracellular vesicles from MSCs can successfully be administered intranasally and have a low risk of immune reaction and rejection. And the phase 1 clinical trials with EEV first in human, I showed you, is currently in preparation. And just to give you an outlook, that this therapy of extracellular vesicle is not being only developed for brain injury, as you can see here, but there is also other preterm birth disorders, including the bronchopulmonary dysplasia, usually the consequence of surfactant lack in these very preterm lungs, but also in the prevention and treatment of necrotizing enterocolitis. So this will probably also come up as clinical application in the future. And I think with this, I want to close with this citation by Valentino Greco, saying that stem cell science is at the pivotal moment and decades of research have the potential to transform human health. And my last slide shows you the team on the left of the Laboratory of Prenatal Medicine. Of course, there's many more also, for example, past postdocs and PhD students. There is the group at Inselspital with neonatology and the pediatric neurology. There is the two industry partners about the stem cell products. And also, of course, there's a lot of partners within DBMR and University of Bern, and funding includes SNF, Eurofunding, and Bangladesh. So with this, I'm finished. I want to thank you very much for your attention.
Thanks, Daniel. That was very, very interesting to see these 20 years of research, starting with sheep and then to mouse models and then going to clinics. And I actually take the liberty to start with a question out of genuine curiosity. So I've also worked with animal models, and one of the questions I'm still asking myself is, how good are these animal models at modeling what we're actually trying to cure eventually in humans? So specifically asked, a mouse brain is very small, and the distribution of these stem cells would, like, just out of spatial geometry, is very small, but a human brain is very big. In your experience, how well can we learn from these animal models about the human situation, for example, in terms of spatial geometry, like just the pure size of the brains?
I think that's an important question, and of course also physiology of the brain. What I haven't shown you, we have also done experiments in human fetal brain, which obviously is only available post-mortem. And with these experiments, where we focused more on the astrocyte issue, because we believe that this is the key cell where with the astrocyte polarization, where the damage but also the repair takes place. So we looked at this in this fetal brain tissue, which is available post-mortem. And also we try to go look at the way how imaging is possible also in these early phases. For ethical purposes, extremely difficult, obviously. But I think there is a need of going different approaches. As you have seen, there is some groups do believe that systemic administration would be better if going through the bloodstream. However, all these cells and vesicles also are these, of course, will end up, most of them, in the lungs. We do have a direct administration, and we believe that this direct administration is effective. I've shown you this study of the Netherlands. So there's an ongoing trial, multi-center randomized trial, and they also try to use some imaging. However, it is on the cell level and extracellular level, vesicle. Anyhow, it's very difficult. So it's a challenge. But when we look at the dose, I think, is also crucial. Maybe you have seen one of the studies of Joanne Kurtzberg's group. They used two different doses, and the low dose group did not have an effect, and the high dose group had an effect on neurodevelopment. So obviously, those will be also crucial things. And what we had used as a baseline is the experience of the doses used in these other trials. So it's what you ask, it's a challenge which we try to overcome with these different approaches.
Thanks for this. Yes.
Maybe I can add, but this will probably not help directly regarding the issue of the administration, but we embarked also on an organ-on-chip approach with mimicking fetal damage, fetal brain damage. So eventually, with this organate, we will be able also to have a little bit more the idea about the dose-effective relationship.
That's exciting. Cool. Thank you. Are there any other questions in the chat? Yeah, I mean, there is one in the chat, but let me ask first to the audience if there is any questions. So there is actually a question in the chat. So Nadia Otero Vasquez asked, in all clinical studies, the control group showed improvement of functions over time. Were these placebo groups, and how do you explain these improvements? And is there a relation to the effect of the stem cells?
Yes, so the issue is, of course, that there is, although the damage itself and the repair itself happens in the acute phase, there is, of course, also after the acute phase in these children, a rather quick development of the brain. So they are eventually, 6 months old or 1 year old or 2 year old. And so they are still in a brain development dynamic. And so the comparator, of course, is also improving, but the dynamics of improvement in this comparative study was better as compared to the control group. Most of the trial were, probably for ethical reasons, not blinded, placebo-controlled. So there is, of course, always may also be a certain bias in several of these studies. But if you looked at these review, individual patient data meta-analysis published in Pediatrics, I showed you there the outcome was pretty clear. And it was also important to see that it is not a short-term effect, it is a long-term effect, which even comes to full form after only 1 year after the treatment.
Yes, so this takes time basically to unfold the effect. Are there any more questions? So Daniel, if I may ask, what do you think are I mean, you have shown a couple of clinical studies. These were all relatively small, and the question is of course, how do you think this can be brought into actual clinical application? So we are still in the early phases of clinical testing. What are the bottlenecks to bring this actually to patients?
Yeah. So I think that's a very good question. I mean, when we embarked on this, project 20 years ago, we were aware that this is not a quick win. That in this field, first, it's an extremely sensitive field. We have a patient population which is extremely vulnerable. And the development is also has a long time range. So I absolutely agree that this will take time, but I think there is clear a way forward, as I've shown you that there are now several randomized controlled trials ongoing, which are of larger populations, multi-center trials. And I think it's clear the time horizon until we can say we do have a treatment ready for these children to improve their health. This will take, I would say, 4 to 5 more years. But I think the most important step is that now the initial phase have shown safety and they have shown efficacy, and now the larger trials will need to confirm and will need to give more details before the treatment can go into a routine clinical practice. And it's important because I regularly receive also emails from anywhere around the world of people sometimes who hear from our research, and they're telling me they do have a child which is eventually 2 years old and has severe cerebral palsy, or 3 years, cannot walk, cannot speak, and they would like to have a compassionate treatment. We don't do it. There is some centers doing compassionate treatment with stem cells. I think one has to be very careful when doing this. But I think the need is really so big, and if this really holds promise, that this will be a really big step for these affected infants.
Yeah, I've no doubt about that. And I actually briefly checked. I didn't find a meta-analysis to pool all these early clinical studies. That might also be interesting to maybe discuss. But I'm looking at the time. Thank you so much again, Daniel, for taking the time today. Big thanks. And
thank you very much. I hope I could also motivate a bit the young researcher. If the time horizon is not only 1 year, but sometimes it takes a bit more time. But thank you very much for hosting me.
Thanks, and talk soon.
Thank you.
Bye,
Bye.
everyone.